Hello student, today we are going to learn about the original anatomy of the upper limb, in which shoulder is our main topic. We will start from the shoulder. So let's begin with the outlines. These are the points of dissection from the anterior and the posteriorly. Let's talk about the shoulder. Shoulder is the region of upper limb attached to the trunk. The bony framework here we go to clavicle, scapula, which form the pectoral girdle, these two bones together, also known as shoulder girdle, and the proximal end of the humerus is also taking part in it. And superficial muscles in the shoulders are coming something like deltoid, trapezius, and this is anterior view, this is the posterior view. So first of all we will go to the bones. Let's talk about the collarbone, which is named as the clavicle. It's the only bony attachment between the trunk and the upper limb. It is palpable, has a gentle S shape, as we can see here. It is having two ends. The acromion end is flat, which is laterally, and the sternal end is a quadrangular in shape, which is middle end. Let's see in an anterior view. Here we are looking for the middle part, the inferior view. We got here on the lateral side the conoid, tubercle, and trapezoid line, which are the actually point for the attachment of the ligaments. Let's talk about the second bone, that is the scapula. Scapula is a large flat triangular bone with the three angles. Angles name represented in the short I mentioned in the bracket. Superior, inferior, and lateral. Three borders, superior, medial, and the lateral. In the lateral is a little bit thick border, medial is thin border, and superior border is also thin. It goes to two surfaces, anterior and the posterior surface. It goes to three processes. We got here acromion process. We got here finger-like projection, that is actually crocoid process. If we look from the posterior view, then we will find the long spine. That is the third process. This is the lateral view. You can see very clearly. And this blue portion here is representing the glenoid fossa, which is actually covered with the articular cartilage to make the joint with the head of the humerus. Something more about the bone marking on the scapula. Here we go. Is it talking about at the lateral angle we got here the tubercle, supraglenoid, and the infraglenoid tubercle, respectively above and below the glenoid cavity. We got here the spine as posterior view. I show you the spine here. Here this was the spine. So at this place above the spine and below the spine, this region we give the name as the supraspinatus fossa and the infraspinatus fossa respectively. And when the scapular spine is finishing at this place, they are communicating with each other. And when it detach from this part, the same extension will change the name as the acromion process, which one is moving forward and making the joint with the clavicle. We got here greater scapular notch. This green arrow place is actually the greater scapular notch, also known as the spinoglenoid notch. Anteriorly we got the anterior subscapular fossa, which is actually directing toward the ribs. That's also known as the costal surface. And the lateral and the medial borders I have mentioned already. We got the crocoid finger-like projection here, and on the superior border we are having a notch, a small notch. We call that suprascapular notch. When the ligament will attach over there, transverse scapula, then this notch will change into the foramen. Okay, so let's see about the proximal part of the humerus. In the proximal part, the head, anatomical neck, we got here the two tubercles here, the lesser and the greater tubercle, which are actually for the attachment of the rotator cuff muscles. We got the three lines here. These three lines are representing the attachment of the muscles, respectively. From the lateral to the middle side, we can come. Lateral lip is representing the attachment of the pectoralis major. Intertubercle sulcus, this place for the latissimus dorsi, and the middle one is for the teres major muscle. The V shape here is the tuberosity. We give the name as a deltoid tuberosity, is giving the attachment to the deltoid muscle. And here the thin vertical line is for the coracobrachialis muscle. Lateral view for deltoid tuberosity. See here in the posterior view on the lesser tubercle from the anterior view and the greater tubercle very clearly from the posterior view. So the lesser tubercle, we are having the attachment of the subscapularis muscle, and greater tubercle, three small facets for the attachment of respectively supraspinatus, infraspinatus, and the teres minor muscle. And these four muscles are known as rotator cuff muscles. Here the three muscles attachment on the three lines of a line, lateral to medial. Lateral one is cut here, pectoralis major, then latissimus dorsi, then teres major. Let's talk about the joints. There are three joints in the shoulder complex. They're named as sternoclavicular, acromioclavicular, and glenohumeral joint. So first picture here in front of us, that is sternoclavicular joint between the manubrum part of the sternum and the middle end of the clavicle. The second joint on the lateral end of the clavicle and acromion process of the scapula. This part here, this joint, acromioclavicular joint. The third joint that is present between the glenoid cavity of the scapula and the head of the humerus. So that joint together we give the name as a glenohumeral joint. Glenohumeral joint is a main joint of the shoulder. For the movement, let's talk about is a synovial ball and socket joint between the head of the humerus and the glenoid cavity of the scapula. Multi-axial with a wide range of movement. The joint stability is by the ligaments and also supported by the rotator cuff muscles, and it is providing the wide range of movement. As the shallow glenoid cavity and the round head of the humerus is providing the great mobility at this place, and the articulations are covered with the hyaline cartilage except for the labrum of the glenoid cavity is formed by the fibrocartilage. The fibrous membrane of the joint capsule is thickened anteriorly in the three locations to form the superior, middle, and the inferior glenohumeral ligaments. The same name as the joint, glenohumeral ligament. The ligament that is coming from the coracoid process to the humerus, we call that coracohumeral ligament. Coracohumeral ligament. After that, we got here the ligament that is skewering the long tendon of the bicep muscle here, that is a transverhumeral ligament. Joint stability is provided by the surrounding muscles, tendons, and a skeletal arch formed superiorly by the coracoid process and the acromion and the coracoacromial ligament. At this place, a ligament present, we call that coracoacromial ligament. Let's see that in this picture we can see the coracoacromial ligament. Okay, when we see the shoulder joint from the lateral view, so it looks something like this. The glenoid cavity, let's begin from here, which one is covered with the hyaline cartilage, and this ring is by the fibrocartilage, and around this portion here we got the synovial membrane. Inside this cavity here at the supraglenoid tubercle, we are having the cut tendon of the long head of bicep. Outside this synovial membrane, we are having the fibrous membrane. Outside the fibrous membrane, these green sacs, which are also cut, they are the bursas. What structures they are present in between, we give the name, just like subdeltoid bursa, subtendinous bursa of the muscles. Now let's talk about these muscles, those here surrounding. So first of all, we would like to talk about the rotator cuff muscles. Rotator cuff muscles, the anteriorly, this muscle is coming from the anterior portion. That is a subscapularis muscle. Superiorly, above the spine, this is the supraspinatus muscle. Posteriorly, this part inferior to spine here, infraspinatus muscle. And below this here, this small one, that is a teres minor. And lower to the teres minor here, we got the teres major. Okay, and the infraglenoid tubercle at this place, this is the long head of the tricep brachiomuscle. This muscle here, that is a latissimus dorsi, and the muscle here that going to attach on the coracoid. Two possibilities: short head of the bicep and the coracobrachius muscle, both are attaching here. And here, this big muscle, that is a pectoralis major muscle. Okay, let's talk about the blood supply and innervation of the glenohumeral joint. This is the posterior view of the glenohumeral joint. So vascular supply to the glenohumeral joint is mainly from the anterior and posterior circumflex humeral artery. Those are making the circumflex around it. And some part is also from the suprascapular arteries above the scapulas. If we talk about the innervation, so the branch is coming from the posterior cord of the brachioplexus, mainly from the suprascapular, axillary, lateral pectoral nerves branches are innervating the glenohumeral joint. Muscles we are going to talk about. Two most superficial muscles of the shoulder are trapezius and the deltoid muscle. Okay, so here we can see from the posterior view trapezius very clearly. Okay, so deep to the trapezius we got here levator scapulae, rhomboid minor, rhomboid major, and latissimus dorsi we have just talked about. Now let's talk about the posterior scapular region. It is located deep to the trapezius and deltoid muscle. As we can see that deltoid and trapezius muscles vanish from here. Under the deltoid and trapezius muscles we can see here the four muscles, and these four muscles are coming like that way. The above the spine we give the name as the Supraspinatus, below the spine the infraspinatus, and here we go the teres minor and then the teres major. So in between the teres minor and major we are having here the long head of the tricep is moving from there. The suprascapular foramen at this place. The suprascapular nerve passes through the suprascapular foramen. The suprascapular artery, suprascapular vein follow the same course as a nerve, but normally passes immediately superior to the superior transverse scapular ligament, as we can see here, not through the foramen. In this picture you can see here. Let's talk about the quadrangular space. The axillary nerve and the posterior circumflex humeral artery and the vein passes through this space. Quadrangular because it is having the four angle. So the boundary of this quadrangular space is laterally we got the humerus, medially we go the long head of the triceps, superiorly teres minor, inferiorly teres major. So this way that we got here the quadrangular space here. So hypertrophy of the quadrangular space muscles or the fibrosis of the muscles edges may impinge on the axillary nerve. So uncommonly these procedures will conserve the deltoid muscles and the atrophy of the teres minor muscle. As in this picture we can see the passage for the axillary nerve through the quadrangular space and the posterior circumflex humeral artery in the vein. Triangular space. This triangular space here we go superior teres minor, inferior teres major, and then laterally we go the long head of the triceps. So this small space communicating between the axilla and the posterior scapular region, the circumflex scapular artery and the vein passing through this gap. And this you can see here. The artery is only mentioned in this diagram. Triangular interval. It got the three boundaries. The medially we go the long head of the tricep, laterally the shaft of the humerus, and superior we go the teres major. So the triangular interval main content is the radial nerve, the profunda brachial artery, which is also known as the deep artery of the arm, and these structures are passing through. So the arteries, if we talk about in the posterior scapular region, so three major arteries: the suprascapular artery we got here, posterior circumflex humeral artery we got here, and the circumflex scapular artery we got here. Veins in the posterior scapular region generally follow the arteries and connect with vessels in the neck, back, arm, and the axilla. Talking about the clinical correlations now. In this radiograph you can see the dislocation of the shoulder, the scapula and the clavicle are in their normal position. Acromioclavicular process and the clavicle are showing the no problem in their junction, but here when we are looking at the glenoid cavity here at this place we should have the head of the humerus, but it is not in this place, so we can see the head here. So that is the dislocation of the shoulder. Very obviously you can observe from the radiograph. Next we got here the subluxation posterior voluntarily. It means that this radiograph is showing that the dislocation happened posteriorly, which is not very common. Actually the inferior anterior dislocation of the shoulder is very common, which one we have just seen in the previous radiograph, but it is voluntarily. It means by force dislocation could happen posteriorly. Next clinical we are having here, the muscle around the shoulder. So this is the view in which you can see the head of the humerus in the middle. Okay, we see here the teres minor, we hear the muscle as infraspinatus, supraspinatus, and the cut portion of the clavicle and also the acromion. We see here the crocoid process, and in this part that we can also see the subscapularis. So it means that the four our rotator cuff muscles have been seen here. Okay, so this part here is representing the simple normal radiograph. Now the next portion here we can see the acromioclavicular joint dislocation, or you can say separation. So here at this place that the normal contour of the clavicle, but here it is a little bit elevated. So let's see that this part in the radiograph. So here is the radiograph in which it is representing the dislocation of the acromioclavicular joint. So here we go to the clavicle and the acromion process of scapula, and you see that the distance is more than the normal. The next clinical is a torn of supraspinatus tendon. In this radiograph we can see here the head of the humerus here, and above that portion that we see the torn portion of the supraspinatus tendon at this place. Next clinical we are having the winging of scapula, which is very famous. It happens due to the damage of the long thoracic nerve, which is innervating the serratus anterior muscle, which is attached here on the medial border of the scapula. And in this condition you can see that the medial end is very prominent. In the book, in the shoulder region and the posterior scapular region, we're having the following clinicals. These are clinicals you need to cover up. Some of them I covered already in the lecture. Some you need to cover up. If you have any problem, then you can contact with me. Thank you very much.